Welcome up Maria Escorcia from JPMorgan Chase. She is, and JPMorgan Chase is our lead sponsor for today, so we're very grateful to them. Maria works for Global Philanthropy, and she's responsible for managing the firm's multi-million-dollar investments in Miami-Dade, Broward, and Palm Beach counties. So Maria, if you don't mind coming up.
Ooh, I almost fell there. Hi, everyone. Good morning. Thank you, Gretchen. And I really just wanted to take a minute. I have nothing interesting, compared to David and Doug. I really have nothing interesting to say. I met them and Dr. King last night at dinner, and very, very interesting folks. Thank you so much for being here. Again, I just wanted to take a minute to thank all the organizations that really work together to make this happen. Catalyst Miami and the Health Foundation of South Florida, Neighborhood Housing Services. All of you guys are really leading exciting conversations here in South Florida, and I'm really proud to be able to work with you and support the causes that you're bringing to the table and the conversations here in Miami. So I just want to say that at JPMorgan Chase, we understand that the success of our firm is directly linked to the success of our communities. We know that a lot of people are being left behind and are not sharing the rewards of the growing economies. Several years ago, maybe 3-4 years ago, we refined our approach to corporate responsibility. And we came up with a model that is really based on evidence and informed by our data that I know you like very much. And it's really to drive inclusive economic growth in the communities that we work and live in. So we are doing 4 things. We are arming people with the skills they need for today's high-quality jobs. We are providing small businesses, particularly minority-owned and community-based ones, with the resources they need to grow. We're investing in community development that revitalizes not only urban cores, but the neighborhoods that surround those cores, those urban cores. And also, we're trying to give households the tools and resources they need to strengthen and manage their financial health. So we've taken this approach to different communities across the country and across the globe, and South Florida and Miami being one of them. So we're doing several things around community development here. And one of those things is also supporting convenings and conversations like the one that we're having here today. So again, I hope you enjoy all the speakers that have really interesting things to say. Thank you for coming today and for being part of this conversation here in Miami. So thank you.
We'll jump into our first panel this morning, very exciting, and we're going to have a great discussion on the role of anchor institutions in building community wealth. This is being led by none other than my dear colleague and friend, Dr. Janice Shoup. Dr. Shoup is the Associate Vice President of Programs, Policy, and Special Initiatives at the Health Foundation of South Florida, and she has tirelessly led the Foundation's newest special initiative, the Community Building and Economic Prosperity Initiative, which seeks to activate anchor institutions in our community around wealth-building strategies and to address the social determinants of health. Janice will tell you more about what we mean by anchor institutions, but please join me in welcoming her to the stage and our panelists.
Sure. Thank you. Good morning. So I have the pleasure of introducing the first panel of the morning. As Dr. King mentioned, the discussion will focus on the role of so-called anchor institutions, which I think the panelists will do a great job of defining what we mean by that. But the role that they play in solving some of the problems that I think we just heard in Doug's and David's presentation around social and economic factors of health, and the role that they play in terms of building healthy and thriving communities. So just to make sure that we make the best use of our panelists' time, you do have short bios in your program book, as well as what the learning objectives are for the panel. So I would want to then introduce each of the panelists We have Dr. Charles Ruthizer with Annie E. Casey Foundation. We have Dr. Winston Wong with Kaiser Permanente. Samira Fazili with the Federal Reserve of Atlanta. And then Jessica Rose with the Democracy Collaborative. The format for the panel, we'll have each of the panelists spend about 5 to 7 minutes. Anyways, that's what they promised. 5 to 7 minutes for a short presentation. And then we will have a sit-down conversation to further discuss some of the important topics that relate to this panel. And then for Q&A, you have index cards at each of your tables. Please write down your questions, and there will be conference staff going around to pick them up so that we can make sure that you are engaged in the conversation. So with that, Jessica?
Hey, it is so energizing to be here with this community that's coming together, so much talent, so many resources in one room, coming together across sectors around a common vision of how we can join together to build the kind of future that we want to see in our community. So congratulations for everybody for being here, and congratulations to the organizers and the sponsors. It's exciting. My name is Jessica Rose. I work for an organization called the Democracy Collaborative. We are a think and do tank that talks about innovations in community economic development. I'm based in Cleveland, Ohio, but I actually am a Central Florida native. I grew up in Orlando. So I've got a lot of roots in this region, and I'm so proud to see all of the great community wealth building work that's happening in this area. The Democracy Collaborative talks about innovations in economic development under a frame called community wealth building. Have folks heard about that before this morning? Community wealth building is a philosophy of economic development that really looks at the way that a system is structured, because we believe that system structure is the source of system behavior. So if you have a system that's set up to emphasize the needs and priorities of a broad-based community, then that's what it will serve. And if it's, contrast to that, if it's not, then it's going to produce different outcomes. So it's all about creating systems that produce the type of outcomes we want to see. Community wealth building, we kind of promote, sometimes it's promoted as an alternative to traditional economic development. I think of it more as a complement. But what we see is that traditional economic development strategies sometimes do little to change the systems that generate social problems like inequality in the first place. Community wealth building is about flipping the script and offering an alternative, about prioritizing local control, inclusive and democratic decision making, so that the decisions that are made with our assets, with our institutions, with our programs, with our communities, reflect more people's needs and priorities. So I'll read to you the definition that we like to promote for community wealth building. We call it a systems approach to economic development that creates an inclusive economy based on local and broad-based ownership. And the way that we work within that frame is we develop place-based assets of many kinds. We work collaboratively, so like we have in the room today, a multi-stakeholder, multi-sectoral group. That's what we like to see: institutions, community economic development, government, finance, getting out of silos, working together, leveraging our shared resources. And within that, one of the strategies that we lean on a lot is to look at a community's assets and to leverage what's there. So for example, in a community like this, which is rich with anchor institutions like universities and hospitals, leveraging the economic power of those institutions can be a powerful tool to create the type of outcomes that we want to see. So what do we mean when we talk about anchor institutions? Have folks heard this term before this morning? So more of us are familiar with that term. Anchor institutions are place-based entities like universities and hospitals that are tied to their surroundings by mission or by invested capital or by relationships to their customers, employees, and vendors. These local economic relationships link institutional well-being to that of the community in which it's anchored. And so we look at anchor institutions as institutions which whose self-interest is tied up in the self-interest of in the interest of the community, and so who therefore have a vested interest in those communities being healthy. We talk a lot about eds and meds, nonprofits. Anchor institutions can be for-profits too. I've worked recently in the community of Rochester, New York, with Wegmans Supermarkets, who's really stepping up to live their anchor mission. Even Tropicana in Bradenton is considering anchor strategies. So it can be for-profit as well, although eds and meds have really taken a lot of leadership in this area. So why anchor institutions? Mostly it's because in addition to being vested in place, kind of sticky capital, most eds and meds, most nonprofit anchors have already a mission that is about community benefit. So if you're a hospital and you're about improving community health over time, how can you make sure that all of your resources are aligned around that goal? That's where we get to the anchor mission. It's about aligning resources so that all of the efforts of an institution are working toward the same end and not in opposition to one another. The anchor mission rather, is to consciously apply the long-term place-based economic power of an institution in combination with human and intellectual resources to better the long-term welfare of communities that they serve. So if you're a hospital who wants to improve, community health over time, and you have excellent, clinical programs that do that. Perhaps you have great community benefits, clinics, volunteer outreach programs, things like that. Maybe also look at areas like your purchasing and making sure that the way that you manage your supply chain is also aligned and serving that same kind of goal. Or the way that you make your investments from your endowment. Are these working, to further those outcomes? The 4 areas that we tend to focus on with the anchor mission, the 4 areas of leverage are hiring, right? So aligning your workforce development strategies to support those goals, purchasing, supply chain, investment, and then community impact. Community impact is sort of the obvious one. The other ones are a little harder to accomplish. We're going to hear a lot of examples this morning from our panel about innovative strategies that anchors have used around those 4 pillars, around those areas. I want to leave you with one example from my current home in Cleveland, Ohio, of an innovative anchor institution model. We have in Cleveland some of the most, some of the greatest leaders in this area. The Cleveland Clinic, the University Hospitals is in Cleveland, Case Western Reserve University. Some years ago, these institutions came together around a strategy of how they could align around those 4 pillars as a collective to benefit the community. One of the great things that came out of that was a program to incubate local businesses that are not only located in disinvested communities, but are also owned by residents of those communities. And they've been able to set up 3 businesses that are built around stated supply chain needs at the institutions, including an industrial laundry and an urban agriculture institution. And these have created jobs for over 120 residents with severe barriers to employment. And it all started because anchors were coming together and asking the question, how can we better use our resources to support the community? So I can see that my time's up. I'm going to pass it on to my colleague Samira, who's got some other examples. I want to congratulate you guys again and wish you best of luck with this morning.
Thank you for having me here today. I'm really excited to be a partner in this effort. For the past few years, I've been studying these anchor models more from a business appeal perspective. What's the economic rationale, especially for hospitals and universities to adopt an inclusion orientation? So not charity, not corporate citizenship. And the 3 areas where I see this shared value, what did you call it, aligned interests? Well, I call it shared value, emerge, and that means an alignment between the anchor's business needs and objectives and the community's inclusion needs. So the 3 areas I've tended to see them align the most in my research is employment, supply chain, and real estate. In each of these areas, the anchor often has a pain point that community developers can help them solve. So most of my talk is going to focus on how New Orleans is doing this. And then I'm going to close with some data on hospitals and universities in the Southeast and in Florida that you may want to think about as you try to design anchor strategies here in South Florida. In Q&A, if you find it helpful, we can talk a little bit about why this business-minded frame is a smart and strategic one and powerful one. So New Orleans is moving from economic inclusion to systems change. Their anchor work is being facilitated by a table that is co-convened by the mayor, the community foundation, and the local economic development agency. And the table helps the anchors work with community to co-design pilot programs that meet shared value. If the pilots are successful, these co-conveners have the potential to scale them citywide. Employment and workforce development has been one of its biggest successes so far. And in Q&A, we can maybe talk about why I'm very bullish on employment, but I want to tell you the story of what they're doing. The Community Foundation recognized that you need training programs that train people for jobs that exist in the community. Surprise, surprise, a lot of workforce development is like a train and pray model, not actually focused on what's available in the community. And so they approached the largest hospital, the largest employer in the city, which happens to be the hospital Ochsner Health System, and said, what jobs do you need? Do you need to be filling? And they said medical assistant position. And it only requires a GED or a high school degree, and you go through a training, you get a certificate. And the foundation helped Ochsner partner with a community college and a local affordable housing developer, a nonprofit, to design and run the training program. And the program was so strong, it made Ochsner say, I'm going to keep working with this anchor table to do more workforce development programming. And the results have been great for the community and for Ochsner's bottom line. The 100 people trained through the original program in 2014 and 15, 94% of them were still employed by the end of 2016. Ochsner gave pay raises to everybody who was a medical assistant because the training program made them realize, we ask these people to do a lot, we should be paying them more. And then on the systems change piece, New Orleans was able to create a great training program that the city brought citywide to work for all the hospitals using its workforce development funding that comes through the federal government. Ochsner has kept innovating with the support of the anchor table. They created an incumbent worker training program, an upskilling program that allows entry-level Ochsner employees to now get trained to be MAs. 400 Ochsner employees have done that. They've created a registered apprenticeship that takes medical assistants and helps them become a kind of nurse, a licensed practical nurse. And since it's a registered apprenticeship, once again, federal workforce development funding helps pay for that. So now Ochsner has a suite of programs that can move employees from minimum wage jobs to this MA position onto a nursing position, all leveraging their HR spend with public dollars. And it creates career ladders for the working poor to move into jobs that pay a family supporting wage. So the second area where they've been doing some great work, really, a minute? No, sorry, is in procurement. The city had, and here the city showed its leadership, the city had an existing what's called DBE program. Anyone know those small business public procurement programs? I'm getting a lot of nods. So the city's program was pretty ineffective, so they revamped it. They streamlined certification, they increased compliance, they provided technical assistance to the prime contractors and the small businesses. And they helped a CDFI, they invested in a CDFI to provide working capital loans to the small businesses. With this infrastructure, they turned to the anchor table and said, anyone want to use our infrastructure? And a local hospital said, sure. We want to try to use your list of certified small businesses. We want to use your CDFI to provide them capital. And that hospital, LCMC Health, in their first year did $2 million in new contracts with local small businesses. So procurement strategies can be slow to start up because of the kind of Byzantine structures. And even if you have leadership buy-in, they may be slow, but they can be very powerful, especially if you design the right ecosystem of supports like New Orleans did. I'm going to close by talking about some factors you may want to consider as you analyze what's the right kind of shared value approach for South Florida. I've been looking a lot at the Southeast because, David's examples were, oh, Connecticut's doing this, oh, San Francisco, we do that. And I'm like, that does not work down here necessarily. So we're different economically, demographically, spatially. So hospital ownership in the Southeast compared to the rest of the country, we have a lot fewer not-for-profit hospitals. In Florida, you guys have a lot of for-profit hospitals, whereas most anchor strategies, anchor mission approaches have leveraged not-for-profit hospitals. ACA expansion did not happen in this part of the country, but I think that provides an opportunity for this work because our hospitals still have a lot of uncompensated care they're offering and high rates of uninsured. So they are looking for ways to community developers to approach them and say, we can save you money, and I think you guys can save them money. Universities, as you look at the universities, think about how we have fewer colleges per capita generally in most of our states in the Southeast, and fewer private colleges compared to public, although Florida's kind of in the middle there. Public universities sometimes face unique barriers to doing anchor work, like procurement is controlled at the state level, not at the individual university levels, in some states, not all states. So really have to understand the context your anchor is sitting in. And then university endowments are smaller in the South, not compared to other census regions in the country. This is not an excuse for the anchor to not participate because there are a lot of smaller universities that are doing anchor strategies. It just may affect the type of work that they do and how much they can deploy towards a strategy. The last thing to remember is our part of the country is a part of the country that houses most of the country's historically Black colleges and universities. They have a history already of being important community anchors. They also often have strong ties and relationships in the exact neighborhoods. A lot of us are trying to deploy our inclusion strategies or our anchor strategies. So, but at the same time, they face a kind of constrained financial environment, and a lot of them do in this day and age. So I want to challenge folks in the South to think about how can you engage your local HBCUs to deepen their support for economic inclusion, or how can they be leveraged to partner with the other eds and meds in town to, if an anchor table are established, to drive these inclusion goals. In New Orleans, the technical assistance I mentioned that small businesses received was done in partnership with a local HBCU. So thank you, and I look forward to Q&A. I'm sorry I went over my time.
I'm Winston Wong from Kaiser Permanente. I'm glad to share this story with you. I actually have a strategy in place, which means that at the end of my presentation, I have about a 2.5-minute video which cannot be interrupted. The other thing I want to ask you is, how many of you are members of Kaiser Permanente? So I was looking at my Federal Reserve. Thank you very much. I didn't expect to see that many members, but thank you for paying for my salary and letting me be here. So I wanted to talk about Kaiser Permanente in terms of, in a few minutes, kind of what the core aspects and elements of why we're involved in anchor institution work. If I had to summarize, it's really a question of our system, our history, and hopefully our leadership in this area. This is our map of Kaiser Permanente. And one thing you have to know about Kaiser Permanente, which you're maybe not as familiar with in Florida, we are in some ways 3 organizations. We are an organization that runs hospitals. We have 39 hospitals, as you can see, and the facilities and the medical office buildings. We are an insurer, of which we have 11.8 million members currently. And we are a medical group. Permanente references the medical group of about 20,000 physicians. So these 3 parts come together to provide an integrated delivery system in which we care for our members. The other way to think about our footprint is everything west of Colorado here are the cannabis-related legalized states, and on the right side are soon-to-be cannabis-related legal entities. So you can think of it that way. But I wanted to just reinforce what our mission is, to provide high-quality, affordable healthcare services and to improve the health of our members in the communities we serve. This is our mission that's been established for 72 years. And we take this mission very seriously. So as you can see, it's not just about healthcare services, it's about improving the health of communities we serve. I come from our community benefit, soon to be renamed Community Health Department, and we think about our accountability across the organization, not in a segment of the organization that is legitimizing our nonprofit status. You saw a previous gear shift kind of graphic that talked about the various contributors to health. But if you think about our mission, we can't think about what Kaiser Permanente does without thinking about the ways that we think about the interrelationship between us being a provider of care, i.e. high quality service, how we think about being affordable, not just affordable against other competitors, but the fact that healthcare is increasingly unaffordable for a greater segment of the US population. And then finally, how do we achieve community health? So if you think about all these three sectors, we cannot achieve any one without recognizing how they contribute in an interrelated way. High quality care, affordability, and community health. Now, I mentioned about systems, and I mentioned the fact that we have actually three components to Kaiser Permanente, being an insurer, being a healthcare provider in terms of our hospitals and our medical offices, and being in terms of clinical services. I think healthcare is going through a transition. Most of the work throughout the country has been focusing on a sick care system, and perhaps right now, with the advent of accountable care organizations and value-based purchasing, as we call it, we're thinking about how to manage and improve the health and well-being of individuals. But where Kaiser Permanente wants to go, and dare say where our healthcare system needs to go, and where we are hearing the message today, is how do we think about that $3.7 trillion that Dr. King mentioned in a way of creating better health for communities? And we have to think about that very seriously. Kaiser Permanente is in for $67 billion on an annual basis. Let me just show you kind of how we're trying to do this. So one can think of Kaiser Permanente in terms of the $67 billion that we're operating on an annual basis in terms of healthcare delivery services. We have really started to ask ourselves, what do we really do in terms of our total footprint in a given geographic area? And we have gone systematically to look at the ways that we really impact communities. Healthcare services is up there, but our treasury, our investment portfolio, how we hire people, the research we do, our labor and management relationships, our environmental stewardship, these are all components of how one would measure the impact of an anchor institution. It's not just about the number of deliveries we provided, the number of surgical procedures we did, but really what we have done in terms of our total impact. We've embarked on this journey in terms of really assessing if we were to arm ourselves with the intelligence of what this total impact is from an economic perspective, from a community development perspective, that we're going to be a much more responsible and accountable organization. So to give you a glimpse of what that really entails, there is a short video. I want to give you a sense of what we're trying to do. It comes from Southern California. So let's tee up that video now.
Kaiser Permanente's always had a commitment to total health. And part of that is because we understand that one's health and well-being and longevity is influenced by where you live and how you live. The Baldwin Hills Crenshaw Medical Office Building is located here because this is where our patients and members are. The people of the community wanted to have an open space that we design responsive to community input. They saw this as an opportunity for economic renewal. They saw it as an opportunity for jobs. One of the aspects of this construction project has been our association with Second Call.
Second Call is a community-based organization that saves lives because we don't deal with the at-risk, we deal with the proven risk. So the individuals who used to use guns and force are now picking up tape measures and conduit, hanging drywall and lifting steel and welding and doing things that are necessary to be a productive citizen. Because without that, it's no use to himself or his community.
I did 27 years in prison. I went in when I was 21, got out when I was 48. And now that I'm back in the community, I'm doing some positive things and I'm re-energizing the community that I did more than my share of wrong to. Joining Second Call and becoming a union electrician, one of the best moves I made in my life. Everything changed. A lot of the stress of what I was going to do had been alleviated because I'm not just working a job, I have a career now.
Kaiser Permanente, they practiced what they preached. They really put their money into the community and gave individuals the opportunity who were ready.
There are people in our community, our neighbors, who've had difficulty in their lives. They need a second chance to build their career, to build their lives. And that's important to their well-being, that's important to their health, and that's important to the health of the community.
They see a person that's part of the community, working within the community, making it a better community by working to provide the community with something that's a necessity.
Our goal is to produce better health, and people who come to work here are on a trajectory from laborer to apprenticeship and beyond. And building a career is a pathway to a better life. Our individual actions are powerful, but our collective actions are even more powerful to improving lives and improving the health of our communities.
Hi, I'm Charles Ruthizer from the Annie E. Casey Foundation, and in the next 5 minutes, I want to do three things. One, to sort of bring you up to date on some of the developments that have been taking place in the emerging field of anchor institutions. Second, to talk about the roles that philanthropy has played and can play going forward to advance this very important work. And then, time permitting, which I doubt I will actually have to go into any great detail, some of the lessons that we have learned by investing in anchor work over the last, actually, about a dozen years. So the Annie E. Casey Foundation, first and foremost, is a foundation about kids, improving outcomes, total outcomes, not just health, but all aspects of well-being and quality of life for the children of America. We realize, though, that we can't achieve our mission unless we focus on helping the families in which these kids live, and then kids and families can't do well unless they live in strong, supportive, thriving communities. So about 2 decades ago, we began to make major investments in community change and community development work in a variety of different ways. But one of the ways that we did was, like many national foundations in the late 90s and early aughts, was by creating a set of national initiatives. Be sort of like Johnny Appleseeds, throwing and dropping initiatives in cities around the country. And one of those initiatives, our best known, was Making Connections, where at its height worked with 22 cities around the country. And one of the things that we learned in the course of doing Making Connections, after being on the ground for not too long, was that in many disinvested communities and neighborhoods that were struggling, there was a large university, a large hospital, sometimes both. But they might have been on Mars. And in fact, many cases, you ask these institutions, they wanted to be on Mars. They wanted to be apart from their community. They built walls. They really emphasized the distinction. They focused inwardly and then maybe globally, but they ignored what was happening across the street, and the neighborhoods and the communities reciprocated. And there was tremendous amounts of mutual antagonism between them. And we thought this was a tremendous and tragic loss and a problem, because these institutions were concentrations of assets, many different kinds of assets. Assets in the head of the head in terms of the skills and specialty of the staff of these institutions, in the heart, in the volunteerism that many of the people associated with these institutions did, but also in terms of what the business side of the house, which was often detached from the social mission. How these institutions hired, they were often the largest employers in town, and how they spent their money in buying goods and services. And so much, virtually all of the money they were spending buying stuff, skipped over these neighborhoods. So these institutions are really disconnected from the social and economic fabric. And we really set ourselves in trying to figure out how can we begin to change this in places that we work and in places where our peers and colleagues are working. And over the last 7 years in particular, we've been generating some fairly positive and encouraging results from investing in anchors. And this, by saying investing in anchors, this is what we sort of mean. We help, convene and catalyze partners, because, bringing folks together and connecting them up is incredibly important and powerful and delivers results. You know, this can happen in an informal way. It doesn't necessarily take a lot of money, but also on the more formal side in supporting the development of networks, communities of practice, and the institutions and infrastructure of a field that allow knowledge of both evidence and experience to circulate. And a good deal of our investments over the last several years have focused on the development of networks. We also advocate, we believe strongly in systems change. We advocate for public policies. At the federal level, there has not been take up, even during the Obama administration, of policies to explicitly support the roles that universities, you could say the Affordable Care Act with hospitals, certainly to sort of foster these kinds of connections. But some of the most exciting work that's going on in the public policy realm is in the local realm, at the level of cities, where we can actually get local policies in motion to help encourage the role of these institutions to partner with their communities in new and more intense ways. We also support demonstrations in particular places where theory is turned into practice on the ground, and then also commissioning research to begin to fill the gaps in knowledge. Unfortunately, most of the knowledge that is within the anchor field is still rather tacit and remains largely in the heads of the people who have been doing the work rather than being committed to formal reports. So I'm so excited about the new report that's coming out from the Fed, the tremendous amount of work that the Democracy Collaborative has been doing, the work that Kaiser has been doing in this field, the way in which the Health Foundation of South Florida and others have been supporting this nascent work coming forward here in Miami. So just a very, very brief look at what's going on, the things that are sort of exciting us in the field. More institutions than ever, not just universities and hospitals, but churches, for-profit businesses are beginning to see the value of using an anchor frame. We're in the midst of anchors going from being a buzzword that's used by, talking heads to something that's actually being used to drive practice, that's embedded in the strategic plans, not just of individual institutions, but systems. And that's tremendously exciting. Also, an interesting development is what we are seeing here is that it's not just the level of individual institutions, but that it's multiple institutions in the same geography are beginning to sort of combine their forces, even though they're competitors in their business, to think about how can we work together if we share a geography, how can we learn together to do this work better. And originally the anchor movement developed in older industrial cities of the Northeast where eds and meds, quite honestly, were the only games left in town when manufacturing and everything else left in the 60s, 70s, and 80s. So some of the more mature, or at least, I hate to use that term, it's so loaded, but at least the partnerships that have been doing this work longest are in places like Baltimore, Chicago, Cleveland, and Detroit, and more recently, Newark. But the thing that's really interesting now is to see the take-up of this anchor terminology popping up in other places outside of the formerly industrial Northeast, in places like Albuquerque, in Denver, in Minneapolis, St. Paul, in New Orleans, and then here in Miami. I was a little hesitant to actually put Miami here, not wanting to be presumptive. But now, most definitely, in the next versions of this PowerPoint presentation, Miami is definitely going to be there. And Casey is very interested in trying to work and leverage the sort of experiences that we've had in investing in this work for a while to help those cities of the second cohort really advance this work. This is part of the evolution of a set of national and local ecosystems that are capturing knowledge. We have a set of intermediaries, we need more. There are several consultants that work and have been focusing on this work for a while that have specialized in working with hospitals and universities about how they do the really hard and messy business of internal institutional transformation in order to be able to do this. It's not just plug and play. In many cases, what we find, it's been a really long road to get institutions in the path of readiness to be able to take on this work and not be responsible for doing it themselves, but to partner with other institutions, the other elements of the already present community development ecosystem, not having to create something new and different, but be part of that. In some cases, universities and hospitals lead in this work. In other cases, they don't lead at all. And that's kind of a hard role sometimes to get big and powerful institutions, and for that matter, philanthropies, to begin to think about doing this. But there are many communities of practice. Anchors as a topic is beginning to sort of pop up on the agendas of many different conferences, trade associations within higher education, within healthcare, and then hopefully, beyond eds and meds within these other for-profit businesses. And interest is growing amongst local governments, although in sometimes, anchor work has evolved as a workaround to dysfunctions of municipal governance. But now I think a lot of local governments are seeing what's being done and want to figure out how can we be more proactive in approaching our anchor institutions and working together to help advance critical goals. And then there's emerging interest within the philanthropic community. A year and a half ago, if you asked me how many funders are really interested in or funding anchor institution work, I could come up with a list of like 6 and 7 that I knew, and I saw them at conferences and we would talk all the time. But we had a feeling that there were more out there, and part of the problem was, people maybe didn't grasp the concept of anchor, so they didn't see its utility. But through the Funders Network for Smart Growth and Livable Communities, which is headquartered just down the road in Coral Gables, we did a survey of TFM's membership. There's 300 foundations of all kinds in the United States. And what we found is that there are 24 that actively see themselves and not only have just started, but have been doing this work on average for 5 to 7 years. And been working on issues like economic inclusion, workforce development, community revitalization, civic engagement. Health is notable by its absence here, but I think that's just a sampling problem. And there are probably even a large numbers of health foundations focused on health that could fit in this. And there's a report by TFN that I urge all of you to see, anchored in place, that talk about some of this work. So I'm out of time right now, and of course I won't get a chance to talk about lessons, but I would love to be able to sort of deal with talk about some of the key signature lessons in our Q&A, because I would very much like to make sure that we have time left over for that. So thank you.
So thank you so much for setting the stage for the discussion this morning. As you have heard this morning, Health Foundation has been engaged in an Anchor Institution initiative, and one of the questions that we get when we're meeting with institutions, whether that be hospitals or universities and so forth, is what's in it for me? So you all are representing different sectors, and I wanted to start with a question from your perspective. How would you answer that question? What is the value of this work for any particular institution? And I'll start with Samira.
Yeah, I think, like Charles said, it's really individual. You have to understand their business and talk to them about their business and what they have to gain from it. I think in this part of the country, workforce development is an area in particular where the anchors have a lot of problems, especially finding people who have middle skill jobs, who have the right competencies to fill middle skill jobs. What Oshner said to me when I talked to them about their work is, we can't recruit people from New York or California to come down to fill these jobs. We have to deal with the local talent pool that we have. And so that requires us to make investments in their education, in their training, because that just helps us. We get better workers that way, we get lower turnover, we get the right results. I think the other thing that's in it for a lot of anchors, which Jessica, you touched on, is I'm seeing climate and resiliency pop up more and more, and that really drives a lot of the procurement interest, because a lot of anchors, I'm sure especially here in Miami, are really concerned about their footprint, going more green, et cetera, and oftentimes procurement's an area where they can really drive whatever climate goals that they have. So those are 2 areas.
Any other comments?
Building on that, it's clear that universities and hospitals, if they're located in disinvested neighborhoods, or even that matter, cities with high rates of poverty, are going to have challenges attracting students, staff, patients, and the like, and keeping them. In fact, after the Baltimore uprising of April 2015, virtually every university in the city of Baltimore experienced very significant drops in the uptakes of their acceptances.
Wow.
And that really caught the attention of university presidents in a major way, and it was one of the reasons why university presidents, presidents of healthcare systems, together with local banks and others, began to step up and say, we really need to be able to sort of make meaningful change happen in Baltimore and address some of the root causes of economic disadvantage and populations that have been disconnected from opportunity. And in fact, I think nationally that's even going to be more reasserted with the growing hostility, contempt for, and questioning of the value of higher education, the public good of higher education in the United States, that more institutions are going to be obliged to be able to do more in the way of justifying their nonprofit status. Quite honestly, if you can't get more, sort of nakedly self-interested than that, to be able to show, to demonstrate what these institutions have been doing, but have not been captured.
Well, I think one of the really important aspects of how Kaiser Permanente looks at this is we're in for the long term, i.e. we have to think about generations. We can't think about what's going to be at the bottom line in the next couple of years with regards to really making long-lasting investments in terms of total health. And if you look at, as I mentioned, our system, if we're going to be accountable for insured individuals and their families, and we think about them through a lifespan of different stages, it really behooves us to think about how do you make the kind of investments to ensure that health of that insured population is going to be as best as it can be, because it's going to cost us, quote, less money to provide kind of the healthcare services that's so expensive. So I think that's a really important aspect of how you kind of frame what the opportunity is.
Yeah, and I'll add just one other thought. Thank you very much for that. Samira, you made a great point about workforce, about it being in the institution, in the institution's interest, that the community have human capital developed so that they can, find the type of, applicants and recruit for the crucial roles that they have. We've seen the same thing with supply chain, that having a network of local, at-scale, stable businesses available is important for an institution to be able to meet its sourcing and supply chain goals. For example, Harrah's Casino in New Orleans has a very robust local supplier program and a diverse supplier program. And speaking with their director of procurement, we were told that having access, where you can pick up the phone and call somebody in your own community, when an order doesn't come or when you need something custom, makes such a meaningful impact in terms of the cost, quality, and service that Harrah's is able to obtain for their business operations. Likewise, I've heard horror stories working with a hospital in Rochester, New York, about a time when their overseas supplier was unable to get them a critical component of IV system, right? And because of that experience, that institution is now looking at a way of onshoring the manufacturing capability for some of those critical components, because they can't withstand another disruption. It's both costly and dangerous. So supply chain is another area. Also, I think we should just throw out that the Affordable Care Act was another important tool in incentivizing the types of investments in long-term community health. Through the Affordable Care Act, we saw, healthcare's reimbursement model shifting to one that disincentivizes recidivism, right? So it's important in the reimbursement system that patients are kept from returning to the hospital and returning to the emergency room over and over. Programs like that are really powerful because they were one of the key, I think, incentives in what you talked about, Charles, more healthcare institutions realizing that their self-interest is inextricably linked with their community's health.
So I think that's an excellent point and a segue for one of the questions, which is, given this shift in healthcare towards becoming a value-based reimbursement system, and kind of it makes sense for healthcare institutions to adopt this anchor mission, why aren't more hospitals engaged in this approach? What are the challenges?
Well, I think the challenges are we are in a stage where the fee-for-service era is still kind of the dominant model. But I think with the rethinking of the financing models, we are kind of transitioning into a value-based purchasing. But value-based purchasing in itself is, again, just another stage. I think value-based purchasing tends to look at what can you get with regards to investing in social determinants of health that relate to disease-related outcome. And I think we have to shift our thinking from disease-related outcomes to really thinking about investments in health. That's going to be kind of the next step in which the further, hopefully, positive genesis of how Americans really think about investing in health is really going to change. I think over the next generation or so, there's going to be a lot fewer dollars going into building great big hospitals. It's really going to be investing in people thinking about how they engage in the journey towards maintaining health. And you'll see that somewhat with the technology sector as well.
Can I add something to that? I think that for those of us who are not from the health sector, who are from community development, we often think of health as like hospitals, but it is also a broader ecosystem. Just like they have to learn, we have CDFIs, we have housers, we have CDCs. There are the providers and then the hospital systems, but there are also the payers in the system, like the insurance companies, Kaiser being pretty unique since they unite both in one. And I think more and more the payers really get this because they're the ones spending that $3.5 trillion. So don't we have United Healthcare speaking at a panel eventually today? And yes. I'm really excited to hear that. I think you'll see that the insurance companies, the private ones, the public ones, whether it's Medicaid, are doing some really interesting things. And even state Medicaid offices are doing some interesting things in this regard.
Okay. In terms of an emerging field, which we know this is an emerging field, how are we evaluating impact? Where is the field when it comes to being able to convey to different stakeholders what is the impact of this work? Give me a good answer.
No, but there's progress. I mean, 5 years ago when my CEO asked me, I go, well, so what's the impact of anchors on outcomes for kids? And I go, well, right now that's an impossible generalizable question to answer because there are no uniform or at least widely used field standards that we're sort of using to track outcomes. And in many cases, the institutions themselves, even though they have loads of data, are not necessarily tracking what it is that they're doing. And in the work that we've been supporting through the Democracy Collaborative, the creating a dashboard, the identification of a set of indicators of impacts on community, we're beginning to see the emergence there, particularly within the university sector. But I think within healthcare, it's been a bit more rapid. And in part, I think, due to the already existing discourse on the social determinants of health. But the challenge also, I think, here is the importance of focusing on data, but the challenges of time. Mm-hmm. It takes a good deal of time, more time than we usually want to think, for these kinds of changes to percolate through the system. And we live in an era where we expect things to happen now or yesterday or whatever. And philanthropy likes to think of itself as being patient capital. We're not. We're not. We think usually in terms of 3-year grant cycles, a year to plan, a year to do, a year to evaluate. I don't know. So we need to be able to sort of change our frame of reference to be able to capture the kinds of changes that are popping up within communities.
Can I make a comment? So I think what we've done, I showed the graphic where we look at total health. One thing healthcare systems need to be accountable for is also the deleterious things we do to communities. So we think that we always do good stuff, but the fact is, a number one polluter in a given community is in fact the healthcare delivery system with all the drugs and the synthetics that are dumped into the system. We do a big carbon footprint with regards to the amounts of energy that we're consuming. We took a pretty sobering look at, and we also have people driving all over to get into our medical systems. We have to look at really a balanced scorecard because you don't take accountability for the deleterious effects you have as an anchor institution. You're not going to really have the formula in terms of how you really create positive attribution to investments.
Can I add, the only thing I'd add on the outcomes thing and the performance measurement is to not forget to measure the financial side of all this, kind of how much funding you were able to deploy towards economic inclusion goals as you're evaluating the social outcomes, because for those of you in the room who work in community development, you know we're always like, how do we pay for it? How do we pay for it? How do we pay for it? And being able to document if anchor strategies actually help draw in more capital to this work is an important outcome that I hope, Charles, you're helping people measure.
Oh, go ahead.
And just one more thought on communicating impact. You know, we're talking a lot about ex post facto, you know, communicating of outcomes, which is paramount, of course. But let's not forget too that an important part of communicating impact is having all, you know, stakeholders from the community involved in the process from the beginning. And so in identifying what the needs are and planning the approaches and prioritizing, you know, I think if institutions are operating in silos, and just doing things to a community, whether those things are less bad or more good, maybe there's an opportunity to even better target those initiatives to, you know, the needs and the felt needs of the community, you know, by greater collaboration. And then, you know, in so doing, you know, generating the buy-in of the community so that there are champions who know what an institution's, you know, goals are and what they're trying to achieve and can help spread that message and you know, bring further allies into the work.
So this is a question from the audience. How do we convince anchor institutions to expand their capacities in ways that diverge from their existing strategic growth plans?
So,
Go ahead.
You have to start. No.
We're over 2 minutes.
Well,
Okay. No, I think we need to start where their strategic interests are,
Yeah.
and be able to connect the dots that their strategic interests are connected up inherently with the expanded mission. Because in an era of, you know, tightened resources and so forth, where institutions themselves are, they don't like to admit it, are run on rather tight margins, they don't necessarily have, although if you're talking about a Harvard or a Yale, or they clearly do. I mean, there's wide variety in the sort of institutional resources that an institution can call upon. And I think we need to acknowledge that many of these institutions, particularly mid-sized, mid-level universities, are facing really serious existential challenges. But we have to be able to show that this works for their already defined priorities. Otherwise, they're not going to be able to get the buy-in and leadership for whom they are accountable to be able to do the work that they need to do. But we can't just stop at their institutional self-interest, where I think a lot of institutions would like to and sort of take a pause, but to be able to sort of push them beyond that.
Charles, I'll add, you know, just tactically speaking, I think one strategy that we've seen really effective is you know, you've got to identify champions within the institution, right? Mm-hmm. So you know, it's not enough for, you know, external stakeholders like us to be promoting this, but it really takes somebody or a group of somebodies in the institution who's going to evangelize for this work, and that can come from the C-suite. It can come from, you know, a department, workforce or procurement. You know, it could even come from, you know, a board, you know, type role, but there needs to be a champion who's waking up every day and committed over the long term to advancing this work from within.
When you have cross-sector conversations about how do we think about this community to really improve the trajectory of opportunity, becomes a much more compelling argument than if you just look at the bottom line of your own single institution.
So we have a lot of representatives from the community development sector here, and of course one of the goals is to bring community development and healthcare together to address these issues and finance. How can these systems work together? How have you seen this work in other areas, other regions, that we can perhaps take from lessons learned of how to go about this work?
So I don't mind answering that one first, because I literally just published a paper on it today. It's on our website, and I'll make sure they distribute it to
It was
folks.
not a plug, by the way.
But there is, in my paper, focus on examples that are happening here in the Southeast, hopefully in context that will feel familiar to Miami. You have a hospital system in Orlando, Adventist, that took $6 million of their community benefit dollars and invested it in affordable housing for homeless individuals, because they realized that It was driving a huge uncompensated care spend at their hospital. Their ERs were constantly seeing the same people because of driven there by homelessness. So I've seen a lot happening there that bring the two sectors together, because which affordable housing developer here doesn't need a $6 million grant to build their developments? And then I think another place we're starting to see some good work, especially in the South, is the state Medicaid offices thinking about outcomes-based finance. So David's new book is a book you probably want to look through. And in my paper, I talk about how both Tennessee and South Carolina, like really, Tennessee and South Carolina are a model, they are, on how you can use what's called pay-for-success finance to drive to bring more money into dealing with the social determinants of health, and how Medicaid offices can do that using Medicaid dollars. So they're in Tennessee trying to figure out how Medicaid spending and the Medicaid insurance companies can invest in fixing some of the home barriers to asthma patients that are irritating their asthma. So clean up the mold, get them air conditioning, but pay for it kind of with dollars that are sitting at Medicaid insurance companies.
Right.
Yeah, well, one thing I think is really important is breaking down the barriers that we have around terminology almost. Healthcare systems talk a specific way. I think financing talks a certain way, and housing and other kind of investment corporations talk a different way. So it's a simple step, but it's actually very profound with regards to breaking down how we talk about these issues in a common lexicon. Because once you get that down, then I think it opens up the opportunity for where shared investments can be made, and you're not talking about different assumptions that we didn't clear up because the terminology got in the way.
Yeah, one good I think terminology in the healthcare field is they're really focused on high utilizers. Is that the right term?
Yes. Yeah.
So that's what
High
these
flyers.
homeless people are. Sometimes a lot of school-based partnerships come with an asthma. They're high utilizers. They use they're the reason we have that $3.5 trillion spend and not good outcomes. So if you are working with a high utilizer population of some kind as a community developer, you may have an opportunity to help the healthcare entity better manage its high utilizer population.
Go ahead if you
And
have.
Denise, one other example of how community development institutions have partnered in this work, I mentioned that we've been a part of a project in Cleveland, Ohio to incubate local community-based employee-owned businesses based on stated supply chain needs at large institutions. Well, in that work, it took really a village and a lot of different sectors to make that successful. For example, there were workforce-related nonprofits who helped the companies that we incubated, who helped them to figure out how to recruit from the target neighborhoods and how to create programming that would make employees, set them up for success. There were CDFIs that came to the table with, startup capital to take the place of the equity that couldn't be raised in these employee-owned companies from a disadvantaged workforce who wasn't bringing capital to the table. City government was involved in identifying land and federal funding sources that they could tap that could help jumpstart these businesses. Then, of course, there were industry folks, right, who brought the required business planning and financial acumen to the program. So, and these pieces happened, independently, but with all of those sectors represented around a table doing the planning and the implementation.
So I don't want to forget Charles' plea at the end of his presentation, lessons learned.
Well, one of them
You have
actually
30 seconds.
speaks to Winston's point about the problem of lexicon. And there are multiple different languages out there. And after having banged my head against this around anchors and spending 7 years, can we come up with a common definition of anchors? Part of it is that some sectors can't abandon their language because that's how they communicate with others in their field. What we need is some kind of more simultaneous translation between languages that allows folks who are specialists within their domains to be able to easily, sort of grasp this. One of the lessons was around time. The other is about space. We talk about the hard facts of data, and we talk about zip codes and census tracts and so forth. However, these lines, especially census tracts don't necessarily accord with the lines of community that people carry around in their heads. And that many of the communities that we talked about as if they were a monolithic, unified thing are actually quite fragmented, diverse, and separate things as well. So I think we need to adopt a bit, at least acknowledge and accept more of the complexity of the community realm, just as we are all too familiar and aware with the complexities of our own particular worlds and how we go about knitting those together.
I think another lesson that I've seen is that places that do this often need an intermediary to help it happen, some sort of community quarterback, if you want to call it that, but some entity that can learn everyone's language and bring them together or hold them accountable. But I do think, because that term has become a buzz term in community development, that it's important to remember that that's often the least sexy job. And it's the most essential job, it's the glue, but it's the least sexy. And often where it works the best is if that organization is really humble and never gets the spotlight at the same time, which is hard in an environment where we're all searching for funding. So you have to be able to be the one that brings everyone together. Everyone commits that you get some money from to be run, but the actual entity running that is doing metrics and data and talking to everyone and giving all of them credit, which can be hard for organizations.
Yeah. So any other 10-second concluding remarks?
Well, 10 seconds. One is, I think it's about what I would call internalized commitment. And I think the heat maps that we saw were really illustrative, because if you look at the heat maps, you say, oh, that's really bad for the community. But in fact, Kaiser Permanente realizes that our own people live in these communities. So that's internalized commitment, and then externalized accountability. If we really think about ourselves as organizations, then how do we think about what we do to really change the health and opportunity in a given community to create equity? And I'm going to use equity in a way that's not financial. It's about equity around opportunity of different populations and vulnerable population groups.
So I think we are up. Please help join me in thanking our panelists. And I know that there was a 20-minute break, and Susan, I need your 10-minute break. So we cut it into your 20-minute break. Hope you don't mind.
Abuse it.
Thank you.
Thank you.